So what's cool is that what's different about this podcast and any other one, we're doing it in our Ardmore location and for PTW. And what's special is that Dr. Milt Zgonis is a different type of surgeon, and I've known Lisa for years now. And so we're going to see some different procedures. We're going to discuss some different procedures that you do and how you guys see sports medicine in general. So there's a uniqueness to, I think, the service you guys provide, how you provide it special. Before we get into all the details and a quick brief summary of each of your backgrounds, I'd like to thank the listeners for checking us out and subscribing. The reviews are awesome, so keep them coming, and thank you guys. So without further ado, let me introduce Dr. Milt Zgonis and Lisa Victorius. So brief background, good on you. Go for it, Doc.
Thanks, Mike. Thanks for having us, by the way. This is awesome. Just a little bit on me. I grew up in New England. I went to college in Boston at Tufts University. Went to med school in Albany. After 4 years there, I came to Penn for my residency. I spent a little bit of time in the lab. Then did a 6-year residency at Penn with a year in research at the lab as well. And after that, I pursued fellowship in sports medicine, orthopedics at Duke, and that was for a year. And then fortunately was asked to come back to be on faculty, and been there since 2013.
Awesome. Cool. Go ahead.
I grew up in this area, so I went to Downingtown, and then I went to University of South Carolina for college, where I ran cross country and track and field. Then I went to...
She was the captain, by the way.
Yeah, the captain. That's a great school. That's a fun school.
At one point, I was the school record holder for the steeplechase.
Okay, all right.
Then we went to Chicago for PA school, and then I graduated, and this guy gave me a job.
I did not give her a job. I don't sign her checks. All I did was say, I think that we will work well together. So
executive decision making right there. But that's a background in sports. Lisa, I'll start asking you a question. I want you to go next, Doc. How has your background in sports contributed to you as a medical professional?
Yeah, well, so my junior year of college, someone took away my school record for the steeplechase, and I was doing everything I could to get it back, and I tripped over a hurdle, tried to keep running, my knee popped, and I could not use my leg or foot. So I had a posterolateral corner, I avulsed my ACL, and had a full foot drop. So that really kind of pushed me into, hey, like I always knew I wanted to do medicine, I knew I liked orthopedics, but that really kind of pushed me into the sports medicine field. And I think it gives a unique perspective to our patients, and I can say, hey, I know what you're going through. I know you're going to get out on the other side of this.
There's an identity crisis I feel like you go through as an athlete. I had torn my ACL twice, and going through that, like who am I? Like I was this person who was in shape and worked out all the time. It's a mentality, it's a way you carry yourself, and that's taken from you.
Yeah, yeah. I mean, when they said, hey, we don't know if you're going to run again, I was like, that's what you tell people. I'm going to go and run a marathon.
Yeah, right. Yeah, look. How many have you run?
4.
Only 4. Yeah, that's good. No, that's awesome. Seriously, well done. That's great points there. How about you, Doc?
Well, for me, sports medicine was very attractive for a variety of reasons. Obviously, loved growing up. I was heavily into martial arts. Actually, that was my main sport, mostly in Tang Soo Do, which is a Korean style. Did that for about 11 years, and in the interim, I became best friends with a guy who is now the number 2 heavyweight in the world in Brazilian Jiu-Jitsu. His name's Jay Mansfield. If you guys are listening to this, like look him up. He's ridiculous. But he's also a super athletic guy, and we just kind of grew up together doing all that stuff. And then had a sister who tore her ACL, had just a boatload of complications. Unfortunately, she had an infection that led to like 17 different debridements and destroyed her joint, and just got to see kind of the nastier side of like sports essentially, and like just what she went through, and really helped shape my desire to work with athletes and to help them out. So that was my impetus, I think.
So coming from Albany down, or the New England area down to Philadelphia, and then down to Duke after that for a 1-year fellowship, and then back to Pennsylvania, UPenn. What was that like? What takeaways do you have from the different regions, from like a sports background and the intensity of some of the people? I know you're from Downingtown, and I'm from Media, Delaware County, so I get it. Not that people aren't intense in New England, so I want your take on it, especially at Duke.
Well, I would say that one of the reasons I actually was fortunate to be at Duke was because of their awesome athletics, right? So D1 everything, their lacrosse program, women's soccer, men's soccer, obviously basketball is huge. Duke football really took off after 2013 when I was down there. So that was really cool to watch. And really when you're working with those kinds of athletes, I think it's cool to just see the interactions that you see between not so much like parents and coaches anymore, but it's like coaches and the trainers and the head team physicians. Like that relationship is not something that you will see at a local high school, just because of the stakes, really, at the end of the day. Half the team went to the NBA, that the year I was there, so we're talking about that kind of a level, obviously. So that was really cool to see. Then bringing it back to here, it really prepared us well for professional coverage. We had the Sixers that year. We also had the 87ers now.
The D-League team.
The D-League team, that's right. So that was like an easy transition coming from a place like Duke, because that's the kind of person we were dealing with all the time, and so really cool that. And then just, merging all together, like all the high school stuff I've done in the past and the collegiate level stuff with the professional stuff. I think we had a great perspective and a great overall ability, from the get-go.
You've seen some high level athletes, so if one walks into your office and your clinic, and it's probably not a surprise to you. You don't feel like starstruck ever, and it's cool. I think once you get those one or two out of the way in the very beginning, you're like, all right, bring on the next one.
Well, they're just human beings, they just have the athlete gene, and they're just really good at that one thing. But aside from that, they're just normal people.
Yeah, so. which makes it fun, because it kind of humanizes them a little bit, at least from your perspective. I mean, we've had a couple higher profile athletes, and MMA fighter in particular, that fights UFC, and it's like, this guy's like normal. He's not always like angry, so it's nice. And now, how about with considering your background and going out to you said Chicago, South Carolina, got some high level athletes. Were you spending any time while you were in South Carolina, like a training room, or obviously as an athlete? But and then in Chicago, like what was that like going through some of those experiences?
Yeah. So I mean, South Carolina, obviously their football team, right?
Right. Sure.
So the track team and the cross country team is not quite on the same level, but you get to use their facilities, which is great.
Yeah, right.
And you get the same doctors, you still have awesome trainers. But it was really great to like rehab my knee and go to the football stadium every day and like use their underwater treadmill and like be like the little tiny cross country girl rehabbing with all the football players. Like it was a lot of fun, and you do see that intensity. Chicago obviously was a very different world, and I was in a different world. I was just studying 12 hours a day,
right,
and running. That was it.
I get it, right? Yeah, but it's not like your mandatory practices and being in the training room or doing any of that stuff. But it's a different perspective, I would imagine. So you come back home. Why UPenn? Why why did you go to the direction you went?
Yeah, because my husband wanted to come back here. Quite honestly, I was like, sure, well, I'll go back. Like, it's a great area. I love this area. You have, and you do have all the sports teams, and you do have all that. And I wanted to be at a place that's going to take care of those people and work with somebody who, our views were aligned, and we want to treat every person like they are a high-level athlete and get them back to whatever it is that they want to do.
So what is it typical? Because I've seen a number of your guys' patients. What is a typical patient that walks into your doors? Like, can you describe that individual?
No.
Good. I'm so happy you said that.
No, we can't, because that person looks so different. I mean, it would be impossible to describe one individual that would encompass that. But I mean, the reality is, the type of work that we do is essentially, at least from an operative standpoint, tends to be just soft tissue reconstruction. So we're not really, while we're looking at the whole body in terms of its alignments and how that influences different problems that can occur. Essentially, our expertise is in things that reconstruct soft tissues, right? So in the shoulder, for example, that ends up being a rotator cuff repair, or it may be an instability case where somebody has dislocations in their shoulder and they have a labral issue that needs to be corrected. In the knee, it could be just about everything except for knee replacement surgery, essentially. So we're looking at meniscus work of all types. I spend on average about a day out of the week in the research lab studying meniscus. All right, so that's a real primary passion and focus of mine. But meniscus transplants, meniscus debridements, meniscus repairs. How do we do that better? Cartilage issues. Potholes in people's cartilage. Like, how do we fill that stuff better? What osteotomies need to be done to correct that and protect that? So as you can imagine, all the ligament reconstructions we do, all that stuff. As you can imagine, really that applies to just a huge variety of different people. That comes all the way from someone who's 15 years old all the way to 75 years old. So you can't pick one
to
person.
Someone who's a high school athlete, college athlete, trying to just go for a run, or someone who just wants to be able to play with their kids or clean their house.
I had a patient of mine who walked in last night. It was a previous patient, and he's getting back in shape, like lifting weights. He's getting the COVID weight off, and he was running on the treadmill, and he has a history of a torn ACL. It's fine to his knowledge, and was running on the treadmill, and somehow lost his balance, felt a pop in his knee, couldn't get terminal knee extension. I told him to try a couple different things to loosen things up a little bit, and he can get terminal knee extension now, but he thinks that there's a flap, the meniscus. I don't know. I said, you gotta go see you guys. Go now, get there as soon as you can, because the inflammation's less now than it was a week ago.
Sure.
But who knows what it is, right? So for someone like that who's in his mid 40s, he wants to make sure that he can continue. He's like, all my goals are, I just want to run and play with my kids. I don't want to do I don't want to play flag football. I don't want to play basketball. I just want to be able to play with my kids. So that's someone that would, especially when you're talking about in the lab with meniscus.
Yep.
That's to me, I think about that. I have 2 torn ACLs in the same knee. I'm going to be there one day. So I'm curious about chronic meniscus tears or exacerbation of meniscus tears that were maybe not such a big deal, and now there was a flare up. How what is out there? What are you guys doing that's maybe different or special? I don't know. Maybe what's changing medicine with that after so much?
Well, that is a super loaded question.
Yeah, right. I know.
There's a lot of content there, and
sure.
I could honestly bore everyone in this room to death for days. Hey, to answer your question about your friend or your patient, actually, that really actually needs to be looked at.
Oh, real for sure.
Because there's not an insignificant likelihood that there is a flip bucket handle tear of the medial meniscus there that's leading to 5 degrees of terminal extension loss, and right. That's all it is, so that person may start feeling okay overall, except for a little bit of pain with weight bearing, and they just can't seem to straighten their knee, and what the heck's going on there, so needs an MRI ASAP because, yep. And the reason why it's so important is because if that tear was going to be just it would be in the short term before it's all macerated by the joint.
You put weight on it, right?
Exactly. So the knee is just it's almost like chewing on that tissue in front of the knee because that doesn't belong there, and that will inevitably wreck the tissue that can't be repaired then.
Right.
Which kind of speaks to what I would consider to be this is a little dramatic sounding, but I actually believe this. I think that in orthopedic sports medicine, probably our generation's greatest challenge in orthopedic surgery anyway, is repairing and restoring meniscal function.
I completely agree with that. Yes.
I mean, we're pretty good at doing ligament reconstruction at this point, right? ACL reconstructions in general, especially if, especially in your average person who's not like a, D1 soccer player or somebody who's at a very, very high risk population, those work about 95% of the time. I mean, 95% is pretty damn good.
Yeah. Compared to what it used to be.
Exactly.
Sure.
That's pretty good. But we're nowhere near with that with meniscus repairs and just getting that tissue to fuse together again and be functional. And as we all know, not having a good functional meniscus produces a lot of problems down the line, especially in arthritis and particularly in active individuals who are pounding the pavement and that cartilage is wearing down, and then we're dealing with a much harder problem to fix later on.
Can you describe like what about the meniscus for some of our listeners who aren't necessarily maybe not in the medical field, or maybe they are and they don't know about the meniscus as much without getting too deep into the weeds, but like what about the integrity of the meniscus? Why is it so easily compromised, and why is it so challenging to like fix? Why can't it just be like, okay, like we stitch it together, it's going to stay that way now?
Yeah.
You know what I mean?
So here's the reason. So it's actually not too complicated.
Yeah.
The meniscus is like a shock absorber in the knee. You have two of them in each knee. One's on the inner part of your knee, the medial one, and then the lateral one's on the outer part. And the thing needs to be intact. It's like a ring-shaped gasket essentially, right? And so if you take it, like one example that I or analogy I like to use is it's like a hoop around a wooden barrel. And if that hoop is intact, then it's holding the barrel together and everything's fine. But if you just take, some shears or something and you were able to cut that metal ring at any one point, then the whole thing springs open and it stops functioning. And that's how the meniscus is too. Unfortunately, that's just how it's made to work. So, when you disrupt it, then the shock absorption goes away and, your cartilage sees a ton more stress. We see on the medial side over 100% more stress. All right, so if it's seeing 100 pounds, now it's seeing 200 pounds. On the lateral side, it's even worse. So you disrupt the lateral meniscus fully, it sees 100 pounds, now it's seeing 400 pounds. All right, so just in terms of the multiplication of stress that
Sure.
cartilage is now seeing, so it's no wonder why arthritis forms so rapidly after the meniscus stops functioning, right? So let's do better in terms of repairing it. Well, that's the problem. It's really hard to do, because the meniscus has almost no healing capacity. When you're a fetus, it's very well vascularized. By the time you're 3 years old, half of that vascularity is completely gone. By the time you're 11, you have an adult meniscus with almost no blood supply at all. So you cut the thing in half and it just doesn't bleed, right? So can you imagine if you had a cut in your hand that you just didn't bleed, right?
Wouldn't heal.
Right. If you tried to stitch it together, you could probably close it, but the stitches would just break at some point, and then you just have a cut in your hand.
Because you're not adding any infrastructure or anything.
Right. So there's no bleeding, so there's no ability for the body to deliver oxygen, nutrients, all the things that are important for healing, right?
Yeah.
In general, as we understand healing anyway. There's some nutrition that comes from the synovial fluid, that's the lubricating fluid in the knee, but that's about it. So in addition to that, you have the effect of the joint fluid, right? So let's say you could get it to bleed, right? Which is really hard, but let's say you could somehow do that. The synovial fluid acts like water from a faucet. Like if you had a cut that was bleeding and you stuck it under the faucet, it just wouldn't heal because the clot would just wash away, it just wash away. So there's the other component of that, because the meniscus is naked in the knee. It's not sequestered from the joint fluid, and it's just how it's meant to function. So when it fails, it's super hard to fix.
Yeah, and I'll touch on the mechanical downstream effects of that. The swelling in the joint, as a result, has a mechanical effect on the muscular inhibition of the quad and so forth. So then, what happens is you have this mechanical structural defect that now results in mechanical defects up the chain and down the chain. The gastroc also atrophies, the quad atrophies. Mm-hmm. So now you have disuse, and then you're going to have compensation in addition to a joint that has poor structural integrity.
Right.
So it's a mess, like you said. But and that's the reason right there, and what you just said is why I feel like it's so important to address. How do we fix the meniscus long term? I've seen patients who are in their 50s get a meniscus scope. Call them scope is what they'll call them. Getting a scope done, and within 3 years they're getting a replacement. So how can we? I guess you touch on the reasons. I'm sure how we can do better at it. What are we doing wrong now? Are we doing anything wrong now? Are we doing the best we can? And we're or is there things we could be doing better?
Well, I think we are doing everything we possibly can. Obviously we're taking into account patients' goals in the future naturally, but the reality is we don't have a good way of predicting what people will actually be like.
Right.
in the future. We have, I say this to my patients all the time, so any of my patients listening right now will know I probably said this to them at some point, but the bottom line is, we don't know if that person's gonna gain weight or lose weight. We don't know if they're gonna pick up a different activity in the future. Are they gonna go, marathon running all of a sudden, or are they gonna be, sedentary? Are they, what kind of stresses are they gonna be applying to the knee, right? So all we can do at times is just treat the problem that we have in our hands now, right? So if the meniscus tears, which it's ubiquitous, meniscus tears are all over the place. Some of them are symptomatic, some of them are not,
Yeah.
So if it's the result of a mechanical dysfunction because there's a fragment of the meniscus that's jammed up in the joint somewhere, that there's not a good way to fix that problem aside from doing an arthroscopy, which is what your patient's talking about.
Yeah.
We have to just get the stone out of the shoe, and deal with the consequences of that later,
Sure.
Now there are definitely solutions to all of these problems, right? So we don't have a good way of restoring that meniscal function, but we have partial knee replacements if needed in the future. I mean, obviously no one wants to think about that, and it's not in my line of work or philosophy to, be thinking about that as the final goal,
Sure,
at the end of the day. But I feel like, for the people that are in really a lot of pain, right, and they just need a solution, sometimes that is what is needed, to just get them going, and get back to life.
Amen. I'm happy we touched on that, because that's, what athlete hasn't dealt with at one point or another, or knows someone who hasn't dealt with a meniscus issue? It's extremely relevant and prominent in sports medicine. So I want to shift gears a little bit, and if you have something to add, Lisa, please take it away. But so I want to get into the dynamic that you two working together. So I've seen you two work together. I've stopped in at the office at times. It's been a little bit, but when I did, so you guys work really well together. What about your relationship with one another? How does it work so well? And I feel like there are patients who will say, listen, Dr. Z's the man, told me what was going on, educated me, took care of me, and Lisa was there for support, she's answered any questions I had, also educated me. So I don't want to take away, steal the thunder, but tell me about, if you want to start, Lisa, about the dynamic and what you have to offer too, to the patient, because a lot of patients will come in and say, and I'm carrying this out, but will say I'm just going to see the PA next time, so I don't know if I'm going to go, or you know what I mean. So the value that you provide.
We've worked together now almost 7 years, and so I think for the most part I know what he's going to say to the patient. So I think being able to sometimes answer the questions for the patient before they can even arise is really helpful. And just managing our time, okay, hey, he's going to talk to you about the surgery, and I'm going to come in and go through all the logistics and do all the other stuff for you, answer your follow-up questions.
Yeah.
I think we are a good team.
Oh,
Yeah.
sure. 7 years, that's work. It takes time to get to that point.
Definitely, and I am, I'm constantly saying that if Lisa wants to retire, then I'm just going to retire. Because I just cannot stomach the thought of having to train another person to the level that Lisa is at. She's the best PA you possibly could ask for, because she said she's super smart, first of all. Second, she knows exactly what I'm going to say, and I don't know. I think that she takes super good care of patients. She's really, really patient, which is difficult sometimes, especially, it just at trying times for patients. Their patience can actually be pretty thin. So I think that she does an awesome job with that. And frankly, at the end of the day, I just really respect her abilities, and her role in the team is critical. And I just acknowledge that. And, she acknowledges my role, and that's it. That's how, that's basically it. You think about any team that works well, it's just mutual respect, and everybody picks up the slack, and we all have the same goals in mind, where we just want to be the best that there is at this particular job.
Sure. There's there's chemistry that comes down to chemistry, in my opinion. A lot of it does. Knowing what Dr. Z is going to be doing, what he's going to say, what he might miss out on, and either reminding him or maybe filling in that gap. It's a huge part of it. It's chemistry, and that takes time to develop that chemistry. That isn't fun to have to develop again and again, and personality too. Understanding each other's personalities, and any duo. Like, you got to know each other's personalities and what they're going to say before they say it. Those are what the great ones do. So I want to know about the complex procedures you guys see, because I feel like the patients I've seen from you guys are more often than not they have an amazing amount of respect for you two, because most of the time you're talking them off the ledge, or you're maybe their third or fourth opinion, and so you see, I feel like you see complex cases more often than not, or I don't know, at least I see the complex ones.
I think we send you the hard ones.
Maybe that's what it is, but nonetheless, I see complex patients from a lot of different places, but I want to know about some of the complex cases you guys see, and what are some of the challenges in seeing that caseload?
Well, let me start by saying that the consequence of competence is pain, Mike.
Thank you. That's the nicest thing anyone's ever said to me.
so if you see a lot of really hard patients from us, it's because we really respect what you do and really appreciate your efforts.
I appreciate that. Thank you.
It's the truth. It's the truth. So yeah, go ahead, take it away, Lisa.
So I think we get, your run-of-the-mill ACLs, but we get a lot of multi-ligament knee injuries.
Okay.
Somehow that just sort of like fell into our laps, and now people are like, oh, you guys do the multi-ligs at Penn, like we're gonna send this to you.
Right.
It's complicated, and it's like you said, pain, but I mean, that's seriously, like, that's great. That's an honor. I would be flattered by that, but that's complicated and they're challenging. So how do you manage them? What do you like? What is different about managing those patients versus someone else?
Go ahead.
Well, I think that that specific patient population has, I would say that's like I guess I'll say I have some, obviously my trauma colleagues from orthopedic trauma that say to us in sports medicine, they say, oh, well, you guys play with sticks and water. We are actually getting people to walk again. And that's obviously tongue in cheek, right? But to some extent they're correct. Like they take a person from 0% and they are trying to achieve like 50%, right? And if they can get that going, that's like a win for some of these really, really severe traumas, right? So in sports medicine, we may see someone who's at like 90%, and we're just trying to get them that where they want to be, right?
The quality of life.
That quality of life that they're trying to get. So philosophically, we just see a slightly different kind of patient population. But when it comes to like a multi-ligamentous knee injury, right? We're doing one of these tomorrow morning, in fact. These things happen where people are having, awful traumas, really bad traumas, foot drops, things like what Lisa experienced, so these are devastating injuries. Like, this is not your standard ACL. I felt a pop playing football. This is, I was in a motorcycle crash and my knee bent 90 degrees the wrong way, and everything went, so what are we gonna do for that person, right? So incidentally, the skill set that we have lends itself to that as well, because there's no other field in orthopedics that does that kind of stuff, right? So it ends up being a sports medicine type of problem, even though it wasn't a sports medicine or a sports injury, I should say, right?
Sure.
So I guess in that regard, we are with our trauma colleagues, with a patient who is really, really in the dumps, like really in bad shape.
Yeah.
And our goal is, real simple stuff. We're just trying to we want this person to be able to go back to normal everyday activities, walking up and down stairs, kneeling, walking in a straight line, simple stuff, without their knee wobbling and making them fall, so we align expectations. That's really important. Educating people about how severe the problem really is. And I think the most important thing that we do beyond the actual reconstructive process and, recommending people like you or some of our favorite therapists to help them out is just to let them know, hey, look, this is like a year. This is a year and a half. This is not like your friend who like tore their little, had a little meniscus issue, you have a way bigger fish to fry here,
Sure.
At the end of the day. So aligning expectations is a lot of what we do in those cases, and really all the cases, like you said, like all the complex stuff that we do, especially osteotomies, patellofemoral work, people are dealing with like instability of their kneecaps or cartilage restoration, cartilage repair. All that stuff takes a long time, and it's really like the subtleties between each case is really important to recognize, and also to communicate to patients like why this is different from you know, your neighbor who had this other thing.
Who had a knee scope.
Oh,
And
right, yeah.
was back
Well,
to
my neighbor-
running in 6 weeks.
Right, yeah, my neighbor's back. I hear it all the time. Well, my neighbor's back to running in like 6 weeks, or his friend. I get a lot from parents actually. Parents probably get it. Ask me that question the most. Well, Timmy on the same team, you know, back to throwing in a month. It's a very different case, and expectations are everything, even from in here. And whenever we're on the same page, then we're good. You know, we're usually in good shape until they try and get 5 other opinions and look for one person that's going to tell them something
Right.
different. But
Well,
it's same thing.
all we can do is just be as honest as we possibly can be and just lend our perspective. And you know, at the end of the day, I feel like that's what people want, right? I mean, most of our patients, I think, really appreciate candor, you know, and not beating around the bush. I mean, no one has time for that anyways, you know, like, you know, you're coming in, you have a problem. I'm not going to sugarcoat it for you. I just can't. I can't do it. It's not part of my personality. I can't do it. And I think while it's sometimes tough for some patients to hear that, I think ultimately they really appreciate it. I don't know.
I agree. Yeah, I think they definitely appreciate it, and especially when you get the patient who is like 4 months in to a long recovery, and they're like, "Man, why am I not doing more right now?" I'm like, "Well, remember when we first met you and we told you this would take you a year?" And then they're like, "Oh yeah, that's right." Okay, so I think they do appreciate it, and I think, you know, we help remind them along the way of that.
Well, I love that you guys have your follow-up appointments pretty regularly. I feel like a lot of other physicians will do their follow-ups like 6 months and then like 10 months or 12 months, and it's like a ways out. But in my opinion, the more regular they can be, the more that's helping reinforce what we're saying. Like it might be a little bit of a roller coaster, but that line is trending up and to the right. Like you're doing well. You just got to make sure we stay on track.
Yep.
You know,
Yeah.
so I love that you guys do that. I think more often than most. At least that's what I see.
Well, I think it's critical to not only just to see people and reinforce the principles we're describing, but we're trying to be strategic about, you know, finding small, subtle problems that can be addressed early. You know,
Amen.
all right.
Amen.
So for example, let's take a person who just had an ACL reconstruction. Surgery went perfectly well. Wouldn't change a thing about anything that we did. The rehab's going great, the patient's doing well, they're doing everything they're supposed to be doing, and all of a sudden 3 months down the line, you know, they're just seeming to like, they just can't get their terminal extension back, you know, and what happened there, you know? If we haven't seen that person, if we haven't seen them 6 months after the surgery, then we would never recognize that they have developed a little arthrofibrosis or a little scar ball in the front of their ACL, and you know, really all we needed to do was just do a little quick arthroscopy, get that little thing out of there, and now they're good again and they're fine, you know, as opposed to, you know, they just did 3 more months of rehab that was banging their head against the wall,
sure.
you know, and not able to achieve that because there's a mechanical problem that was just not seen, you know, or recognized. And you know, I hate to say it, Mike.
Please do. I hope you're going where I'm going to go.
I hate to say it, but
No.
the reality is, like, not every physical therapy place or person is accustomed to these issues and or recognizes that stuff to say,
Right.
hey,
No.
Dr. Z, you know, Lisa, listen, like, we think this is what's going on. You should probably see this patient back.
Yeah, I was going to say.
You know,
Yeah, like we love the text message of it. This person's doing great, or hey, you got to see this person because this is what's going on.
Right.
yeah, because
Very
you know,
Huge piece of it.
yeah, I mean that's why we feel like knowing the physical therapist, not the therapy place, the therapists.
Thank you.
Are
Thank you. I say it all the time.
It's critical, right? Because at the end of the day, you know, we know that our patients are in good hands, right? We did a 1 hour surgery that is taking 9 months to rehab, right? We recognize that is,
Sure.
you know, a huge component. I mean, I tell my patients all the time, and Lisa does too, like, you know, look, you know, we did 1 hour worth of work on you. The rest is on you and in physical therapy, and I value the therapy equally with the surgery that's done.
I appreciate
you know?
it. Thank you.
No, because
No,
that's the reality.
I agree.
You know,
Thank you.
the outcomes are so
Yeah.
much better when you have someone who's skilled and knows what they're doing, and you know, our patients are being well taken care of and looked after. So we feel good about it. We sleep well at night knowing they're in good hands, and that's really what it comes down to. I like to sleep. You know what I mean?
Yeah,
Like
he
I don't.
loves his sleep.
I
It's
can't.
very important to him.
That's another reason I'm in sports medicine. I don't want to be called at 3 a.m. with a trauma. You know, like it's one of the things I value. So I want to go to bed at night knowing that, you know, everybody's in good hands. You know, and that's it.
It comes down to trust, and for us too. Like there are patients, like the one last night. Okay, who should I see for this? You know, drop your guy's name. So, like, and I know I can text you like, hey, look out for this call. They're gonna be, you know, this is what's going on. This is what I'm seeing. So, you know, let me know how it goes. And I think I'm pretty sure I do this. I say I do it. Let me know what you guys are thinking. Like, if there's something like you said, like, this, you know, work on this or work on that, or you know, I tested like glute medius strength. Like, what do you think? Like, it doesn't look too hot, man. What's the problem? What's going on? So those dialogues to me, like, you're not gonna hurt my feelings. You know, tell me. Like, we need to know. And PTs out there, like, don't be too proud. Like, we have to rely on each other, and don't keep trying to hit your head against the wall because they're not getting terminal knee extension because there's something physically blocking that terminal knee extension. So communicate. Like, that's the name of the game.
Yeah.
That's how you develop trust. You know.
I would agree with that, and also I think that one thing that Lisa and I do particularly well is receive feedback from you guys. You know, so we're never ever, especially coming from a trusted source, we're never ever going to dismiss a comment. You know, so if somebody says, you know, I'm just not sure about what's going on with this patient, it's like, bring him back in. We need to look at it. You know, and it may be nothing. Or maybe we just categorically disagree with it, but at least we, you know, we're saying, okay, well, we're gonna just check it out because this person has a degree, they have experience, they have a different perspective on what's going on, and maybe there's something we've missed or we just haven't seen the person in a while, and you know, no one's perfect, right? But together you can be as perfect as you possibly can be. You know what I mean?
Amen. That's the name of the game. I love this. Is great stuff. I could do this all day. I know we got places to be, but yeah. So just to summarize that, communication's everything. Being humble enough to accept criticism, and then offer your insight on things without being afraid to do so. From a PT's perspective, I think would happen more often. Is also important, and in the end, it's for the good of the patient. That's why we're doing this.
Exactly right. We're here to take care of patients and get them back to doing what they want to do.
I'm letting that finish up. Do you got anything else to add? Anything else you guys want to cover?
No, this was awesome.
Yeah, thanks for having us.
Yeah, thank you guys. That's a wrap.